And there we go. And once the forum is complete, we will also have a transcription of all of the comments and save the recorded event by a secure server. Obviously, not all feedback can be gathered live during this session, so we would also appreciate any written feedback that you may have following the forum. And I'll just ask that you send that within the next week. So by the end of the day on May 4th would be appreciated, and we will try to integrate your feedback into any future materials. All right, with all that said, let's kick off this presentation. All right, for today, I am going to present an overview of the methodology that we use for the benchmarking analysis and the process of creating rates from those benchmarks. I'm going to try to keep those comments relatively brief to allow some more time for your questions and comments, but we wanted to make sure to cover that methodology for those who have not been able to read the methodology document that we have posted online yet. For a little bit of background, as Michelle mentioned, dental services in MaineCare were heavily impacted by COVID. So while total spending actually stayed relatively constant and even increased slightly from pre-pandemic to the last calendar year, that's actually a negative story. There's been a decent decrease in the number of providers who have billed services to MaineCare, decreasing significantly in the years since the pandemic started. Besides that, while spending has stayed constant, member enrollment has increased significantly during the pandemic and because of MaineCare's expansion. So children's enrollment has increased by 18% and adults enrollment has increased by 38%. So if spending has stayed constant but enrollment has increased, that means on a per member basis, many fewer people are actually receiving dental care. As you can see from this trend graph, when the pandemic hit, dental services were extremely impacted. This is the percent of members who received any dental services within each given month. The orange line up top shows children's utilization, and the blue line at the bottom shows adults. So even after the initial lockdown and the pandemic lightened up a little bit, dental services never really fully recovered, and children's services have just kind of plateaued 20% or so below where they were pre-pandemic, and adults also haven't quite gotten to where they were. They weren't quite as dramatically impacted by the reduction in services, but only because they were not really receiving any volume of services prior to the pandemic. So that is the current state. The future state that we are hoping to build shows $45 million of new dental investment that was passed in the governor's budget. That is on top of $21 million in current spending. Those are that's spending for calendar year 2021 on Section 25 services. $8 million of the new investment is going to be specifically in rates. So that $8 million is saying if all services, if the benefit stayed exactly the same, if the utilization volume stayed exactly the same, the rate changes alone would add an extra $8 million in additional spending for main care services. Another $37 million on top of that is the amount of investment we are anticipating for the adult benefit expansion. So that would cover the new codes, the changes to PA requirements, any additional utilization that adults will be experiencing once the benefit goes live. And all of that will also mirror the same rate investments. So the $8 million isn't the only investment. That's just that baseline number where if everything else stayed constant, the rates alone would add $8 million. That $8 million is a 37% increase in spending overall. And we have prioritized investments in more preventive services. So if we look specifically at the diagnostic and preventive rates, we will be increasing that spending on average by about 70%. The flip side of those numbers means that the average provider of dental services who sees main care members will experience an average increase in their main care revenue by about 37%. And that number will obviously vary provider by provider depending on your mix of services. So the general approach to setting dental rates was based on as Michelle mentioned, the comprehensive rate system evaluation recommendations from over a year ago. Those recommendations were to use commercial insurer data to determine benchmarks for each service and then set main care rates as a percent of that commercial benchmark. As we dug into the data, we realized the services that we cover, there just weren't always benchmarks available, and the benchmarks weren't always reliable based on the data availability. So we also looked second at a set of Medicaid benchmarks. If the commercial benchmark didn't meet the criteria for reliability, then we would look at Medicaid benchmarks and set a rate based on a percent of Medicaid. If neither benchmark was available for some reason, then we would take that back for further review and determine a different methodology for determining the rate. There are codes where the rates are set in relation to each other, whether that's a quantity of teeth, the age of the patient, or so on. Then we did a further review of those codes to make sure that the relationship was consistent. If the benchmarks led to an inconsistent relationship, then we would adjust one or more of those rates so that the progression through the series made sense. So to get into a little bit more detail about the benchmark analysis, we used commercial claims data using dental claims that were available in the Maine Health Data Organization's All Payer Claims database for the most recent 12 months of data that was available at the time we received it. So that was July of 2020 to June 30th of 2021. We first looked across all of those claims and calculated a total allowed amount. That includes both the payer responsibility and the member responsibility. So that's the paid amount from the payer, the copay, the deductible, and the coinsurance all combined. And that was the rate at the claim level. And as our commercial benchmark, we used the median allowed amount for each service, for each code as our benchmark. The Medicaid benchmark was different. We didn't have claims data available for all Medicaid states. So instead, we looked at all fee schedules that are available on state Medicaid agencies' websites. We downloaded those and compiled every rate for every state and calculated our benchmark as the average of all other states' Medicaid fee schedules. If a state simply just didn't list a rate for that code, then they were removed from that benchmark calculation. And some states have rate differentials for adults and children. We weren't going to create a rate differential ourselves. So we averaged those two rates to come up with an average rate for any state where they did have that differential. So just to walk you through an example, a fairly straightforward example of how this worked. For comprehensive oral evaluations, we looked at DO-150. Our current rate prior to any adjustments is $55 exactly. The commercial median allowed amount was $90, and the average state Medicaid rate was $36.66. Sorry. To determine the rate that we pay off of that benchmark, we started with the recommendations that came from the comprehensive rate system evaluation, where we would pay 67% of the commercial benchmark for what we've been calling priority services, diagnostic, endodontic, periodontic, and preventive services by service type. For all other services, we used 50% of the commercial benchmark. And because we had to also use Medicaid benchmarks for some of the services, we used 100% of Medicaid for the majority of the services, and then for the priority services, we simply mirrored the differential that we gave on the commercial side. So that was 133% of the Medicaid benchmark. Excuse me. So to go back to our comprehensive oral evaluation example, we, since we had, excuse me, since we had a commercial benchmark available, we first looked at that benchmark. We took 67% of that benchmark. And then one of our recommendations was also to inflate the benchmark, since it was based on historical data. We are recommending to add an inflation adjustment of 2.34%, and that got us to a recommended rate of $61.41. there, excuse me again. There were a few exceptions where we had clinical-based reasons to deviate from the standard methodology. Using the standard methodology approach, it created concerns about access to critical care for certain services. So, so we are applying some alternative benchmarks for these services to avoid those potential access to care issues. These alternative benchmarks will be temporary, at least for extractions. It will be temporary as to provide more time for the expanded dental benefit to reduce the need for those extractions. So just to walk you through those two exceptions, the standard methodology for silver diamine fluoride would have had us using the 67% of the commercial benchmark that was available, and the benchmark appeared reliable from the data, but it would have cut the rate more in half. And as a preventive service that may delay or reduce the need for extractions, we determined it was appropriate to use the Medicaid benchmark. And as a priority service, it was 133% of the Medicaid benchmark. That recommendation brought us to $25.70, so just a small increase above the current rate. For extractions, the standard methodology would have had us using 50% of the commercial benchmark, so about a $10 reduction from the current rate. But we've heard repeatedly that oral surgeons are in great demand, especially for MaineCare members, and a rate decrease for the extraction code would have heavily impacted oral surgeons and caused potentially more issues with access. So as an alternative, we applied that same priority percent, so 67% of commercial benchmark just for the 7140 to get to a rate of $110.40. Before we get to questions and comments, I just wanted to share quickly that we do have a methodology document available online. If let me share this webpage. There we go. So if you go to MaineCare's projects and initiatives webpage, we sent a link out to this in an e-message last week. But if you do not receive that e-message, this is publicly available. You can see a draft methodology as well as a table of our draft rates. So if you want to review, if you would like to review any of those in more detail, you are welcome to do so. With that, I will pause and we can open up the floor to any questions or comments.
Dr. Ranke, you can unmute now.
Hello, can you hear me?
Yes.
Hi, sorry, my service isn't great. I just I went in and out with my last couple of patients of the day. Hearing some of your presentations, so I apologize if you've already addressed this. Little background on me: I'm an orthodontist that currently works for Jesse Albert in Bath, Maine. Just taking a look at some of the orthodontic codes that were there and being billed for. It seems that the data for the comparables with the states that we used is not accurate data for just something to reconsider. It's not really an apples to apples comparison. By that, I mean, in some of the states that you have listed as significantly lower reimbursement rates for orthodontics, specifically for the 8080 code, those states are allowed to bill that code on multiple occasions. So the total sum is actually considerably higher than the sums you have listed there for whatever that's worth.
Yeah, thank you for that comment. We did do more looking at the orthodontics data for both the series of the comprehensive set of codes and for the limited set of codes. Our rate recommendation is based off of the commercial benchmark rather than the Medicaid benchmark. And to make sure we were getting an apples to apples comparison, we limited the commercial data just to claims where only a single claim was billed for a given member, so that we could have that apples to apples comparison. We didn't have a more than a year of data, so we couldn't guarantee that we could capture a full series of treatments with monthly billing. So we attempted to correct for that by limiting to members where only a single instance of that code was billed.
David, when you say a single instance, you are identifying the comprehensive code versus, I'll call it a piecemeal approach. Is that correct?
That's correct, yeah. Let's see, I did get a question through on the chat from Dr. Desjardins. She asks, is this similar to how other rates are set for other provider types? For that, I'll say we do typically use other fee schedules as benchmarks when they are available. Often we prefer to use Medicare fee schedules when they're available, but that just simply isn't available for dental services. For other services, we do use the average of other Medicaid states, but we have not used commercial benchmarks up until this analysis at this point.
Lindsay, you can unmute.
Hi, can you hear me?
Yes, thank you. Go ahead.
Okay. I'm a main care provider. I'm a denturist actually, so I only provide dentures, partials, things of that sort. And I had a question. I looked at the paperwork and it looked like the prior authorization was not going to be in effect anymore for dentures and partials. So I had a couple concerns. One concern was that, most of our patients are denied through the prior authorization process. So most of them actually won't even go through it. They just get their dentures self-pay. And did we account for that and how much we're going to be paying for dentures in Maine? Also, my next question is about partials and how we derived kind of to that fee, because unfortunately in the self-pay world, the partials are actually more expensive than conventional dentures. And in the fee, it's very much the opposite. So I just kind of wanted to know where that came from.
Sure. So on the prior authorization question, I will need to defer that to our policy unit. They may not be prepared to speak to that today, but I will ask if they have any quick responses on the prior authorization piece.
Sure, thank you, David. So I don't have a complete answer, but certainly the issue of looking at when and whether prior authorizations are necessary is part of the review that we're conducting as we look at the service component of the new policy. So we haven't fully presented that yet, but it's an important consideration.
And just as a reminder, and I'll look to my team as to, I'm not sure whether we've shared any information about our upcoming session yet, but we will be having an upcoming session where we will go into detail about our proposed policy for coverage. Have we sent out that day yet? I'm just coming back from vacation, so I'm still trying to catch up with where we are. We haven't. Okay, so in the near future, we will be sending out a save the date. It will probably be it'll be this in the month of May, where we'll be able to get into more detail on the coverage piece.
Okay, Round,
Thanks.
please.
I think there's a second part of that question, right? Sorry.
Right. Yeah. So on the rate portion of the question, I'm not recalling any data issues off the top of my head. So I believe those partial denture codes would have had their rates set according to the normal benchmarking process. If there are specific codes you'd like to follow up on in writing, then that would be appreciated. We can take that back and do checks with more diligence on those. All right, I think we can now proceed to the next question. Kay Round, yes.
Hi, good afternoon. My name's Kirk Round. I'm an orthodontist in Maine. I help with Catholic Charities in Maine as well. And just to support what was said earlier, I appreciate what you were saying during the benchmark analysis, how we tried to do it where they did, one submission for a claim, but there must be some issue with the data there, because having worked in some of those other states, instead of being $500, that really is closer up in the mid, 35 to 4,000 range. So if there's a way we could look at that, and how can we submit more data? I know, for instance, South Dakota has over $4,500 for an orthodontic case comprehensive for that D8080 or 8090. And that it is really tough to separate the wheat from the chaff there for sure. But, if we could just look at that in a world where these cases that are approved have to qualify and be so difficult that they take longer than an average case, and not to mention, the travel time and some of the other challenges treating these, that it just seems very, very tough to try to meet the benchmarks we want to meet with the current rates right now. If we could look at that, who can we submit more information to?
Yeah, so let me address the first portion first, just for clarity. Our current rate for the 3 different comprehensive orthodontics codes is $2,725, and our recommended rate as a result of the benchmark analysis was $2,931. it's not going into the hundreds. It is a small increase, and that was again based off of the commercial data, not based off of other state Medicaid agencies.
Yeah, I think a lot of times those people end up doing additional codes though that may not even be picked up as orthodontic codes, just as like panoramic radiographs and things like that get reimbursed for additionally as well.
Yeah, and we welcome any other written feedback that you want to provide. If there's more context that you want to provide in follow-up, then Jessica Levesque, the rate setting analyst, her email is listed as the point of contact to gather that feedback. So she'll be compiling any additional follow-ups that you would like to provide.
Great, thank you so much.
Yeah, thank you.
Dr. CJ, please.
You guys hear me?
Yes. Yep, we can hear you.
Hey, name's CJ, dentist up in Millinocket, Maine, Petton Valley Health Center. Just two quick questions. I might have missed it because I was kind of driving and listening to you guys. Well, don't tell anyone, but I am off the road now. I was listening to the denturist, and I utilize a denturist here. With the changes, I was kind of curious if there was going to be, because dentures do wear out after time, if there's going to be some sort of, like after 5 years, after 7 years, can it be redone or essentially refurbished or what have you? And the other question is that up here, we don't go by rate, we go by a per encounter. Will there be a consideration to increase the per encounter rate for places that do that?
Sure. By places that do that, are you referring to FQHCs?
Yes, we are an FQHC. Yep.
Okay, great. Yeah, so everything that we're talking about today with regard to rates applies to providers who bill under Section 25. If you bill as an FQHC and have an encounter rate, then these fee-for-service rates won't necessarily apply to you. So if I think we would need to discuss in more details with the policy unit on any implications for other sections of policy. And with regards to your first question on benefit limits for dentures, whether those are allowed with any frequency, that would be another benefit question that I'm not prepared to speak to. And again, the policy group may not have an answer available today.
Yep, thank you, David. And I don't have an answer if one of my team has a quick and easy answer on dentures and whether they can be refurbished. I'm fine with us answering that. If not, we can speak to it at the next session.
Thanks, Jenny.
I have a comment in the chat to me. Can the rationale evidence for limiting the increase of the extraction code D7140 payment to 24 months be explained? And this was Danielle Altieri.
Sorry, I'm not sure that I saw that full question. I'm trying to see if I can access the transcript. Can you paste the question in a chat to me so I can see the full thing?
Sure. not letting me paste it, David.
Oh,
Can I just, want me to try to read it one more time?
yeah, please.
Okay. Can the rationale / evidence for limiting the increase of the extraction code D7140 payment to 24 months be explained?
Okay, thank you. Sorry, I didn't get that the first time. I'll take a stab at this, and I'll let Michelle chime in as well if she'd like to. But through our rate reform process that we're committing to, we have committed to rerunning this analysis every 2 years. So in 2 years' time, we will be recalculating both the benchmarks and potentially redetermining an appropriate percent of that benchmark. So in 2 years' time, we will be taking another look at that code, and so that's kind of the limitation on why we're proposing this as temporary for 2 years. Michelle, would you add anything to that?
Thanks, David. I'm glad you got the question on the second time, because I still don't think I interpreted it correctly, but with your answer, I get it. So I will just further say that with our standard methodology, this was based in part on feedback that we received from providers during our rate system evaluation. As David shared, we are paying at a higher percent of benchmark for the diagnostic, endodontic, periodontic, and preventive services, in part because those services, in addition to being preventive, also just as I'm sure all of you are much more aware than I, can prevent further costly interventions and improve quality of life. And so that was the policy decision that was made. Under that standard methodology, extractions don't fall into the category of the services where we're providing additional incentive, additional reimbursement because of the importance of those services. As a result, when we went through our standard methodology, extractions, the rate we pay for extractions would have decreased. We recognize that would be problematic right now and not something that we wanted to do given current access issues, as well as the fact that we haven't had a robust adult dental benefit. And we are well aware that many of the services that have been provided to adults are extractions. And so, in the long term, I think we all share the goal of getting to a place where there is less need for extractions. So after a couple of years, I would like to reassess, as we don't want to provide a higher incentive for extraction services versus the services that we really want to prevent extractions from being needed in the first place. So that is why, as a temporary measure, we are reimbursing at the higher 67%. Did I get that right? Yes, at the higher 67%, so that we don't exacerbate the issue. But after that point, our intent would be to go down to the 50% benchmark, because that is more consistent with our overall methodology. But we would certainly reassess to see how we were doing with extractions at that time.
Thanks, Michelle. Before we get to the next raised hand, I just wanted to acknowledge I have a few questions in the chat asking for more details about the prior authorization changes. So again, I'll note those will be changes to the benefit that the policy team can speak to. Jenny or Derek, has there been anything published publicly about those changes at this point, or is the plan to address it in the next forum?
I don't think we've published any details. Derek, please correct me if I'm wrong. And we do have a date for the forum, which is May 18th. So the email on that should be going out next week.
Great, thank you.
And just for awareness, we had talked about trying to talk about everything in one forum, but we knew that there was significant interest in rates, and we were concerned that we didn't want to keep everybody very late in the evening. So thanks for your patience on that.
Thanks. And recognizing we only have 5 minutes left, we will still try to get through all of these questions. I am happy to stay a little bit past 6, but I don't want to keep all of you too late. Again, we'll be happy to follow up with any questions or comments in writing if you have them. So with that, Lindsay, you are free to speak again.
So, I know that this is probably a moot point at this point, but unfortunately, a discussion about rates without a discussion about policy is not really, it's very difficult, because that's the limiting factor of MaineCare, is the rules and the policy. You know, if you could bill every, you know, for dentures, MaineCare says that a rebate, a denture, and an adjustment, only one of those things can be billed once every 3 years. Well, that's unrealistic, and that's why you have providers that are not taking MaineCare. And for extractions, we're lowering the root tip code, the 5250, and we're only increasing the 5140 for 2 years, and then we're going to lower it, is what it sounds like. And that is going to cause a huge problem, because no matter if we increase preventative at this point, we have not provided preventative services for 30 years. And unfortunately, we have a huge pool of people that are not going to be in that situation. And when you decrease those services or do not change the policies, you are not going to have access to care. So unfortunately, I think that policy and rate go together. And we can't have a conversation about how these rates are appropriate without looking into how we're billing them and the policy.
Thank you, Lindsay. And again, due to time constraints, it is difficult to fit in conversation on everything all at once. We absolutely agree that rates and policy go hand in hand, and that is why we have been conducting a comprehensive policy review at the same time as we've been looking at the rate review. So I very much hope that you are willing and able to join us on May 18th so we can get into more detailed conversation on the policy side, and we will also be providing, I think, a recap of rates at that time as well.
So can we, specifically for a rate thing, can we talk about how the root tip is going down? Because I believe that that is the 5250 is going down at this point. I'm sorry, 7250.
Sure. So that rate would have been set again based off of our standard methodology. I'm happy to take another look at that rate and confirm that. Unfortunately, with the methodology that we use to be able to have a consistent methodology, we can't guarantee that every rate will go up. We need to establish some benchmarks, and it was inevitable that some rates would go down. But we'll be happy to take your comments back and look at that code in more detail.
Okay, thank you very much.
Yes, thank you. Next, I have Becca Matasovich. You should be able to unmute now. maybe.
It looks like you were for just a hot second,
Okay,
Becca. There you
we
go.
go. There we go. It kept giving me a message. I couldn't unmute. Okay, thank you. Yeah, I want to say first that like, I just think this is also really amazing. And, you know, we should take a second to thank you guys for all the work that has gone into this because, this has been a long time coming and it's a lot of work to put this stuff together and to find a new way of setting rates in a logical way is really important for many years to come. So I think that's deserves a lot of credit. And there are a couple things that I just wanted to mention for maybe like just for further looking deeper. Like, I'm not sure I have a specific suggestion, but things that just struck me in looking at it. And I am not a provider, so I'm coming at this more from the sort of patient community access standpoint. But it seems to me like in the first four, right in the first four in the list, the periodic oral evaluation, limited oral evaluation, the DO-145 for the primary care oral evaluation under 3, and then the comprehensive oral evaluation, there's some big changes there in the draft rates. And it's great to see the ones that are too low going up, but the order of them has kind of flipped. And that strikes me a little bit odd. Like it felt to me, based on what I understand these services to be, like they were kind of in the right order before, even if they were too low. But now in the draft, it's like an oral evaluation for a patient under 3 in primary care would pay more than a periodic oral evaluation of an established patient in a dental office. And like, that doesn't seem right. So there's something about the 4 of those that don't seem to be in the right order anymore. And far be it from me to argue for anything to be lowered. But I think the mix of those isn't quite right yet. So I just wanted to raise that. And then I'm wondering if I can see with 601, 602, 603, that carries risk assessment. I know they're not going to be covered codes, but I see in some other places where you have like used for reporting only. And I'm wondering if that's something that we could start to look at with those risk assessment codes to start using them, at least for sort of data gathering and learning processes too. So that was a quick thing. And then on fluoride varnish 1206, I was wondering if you're going to look at CPT 99188 for the fluoride varnish in a primary care by a primary care provider, and if that will be parallel, because that might be an important thing for a number of reasons to keep those codes parallel. And then the last thing I wanted to mention was case management, and I was really happy to see at least one case management code getting a fee. I think especially in these next couple of years between the pandemic backlog and the workforce shortage and the new adult benefit, there's going to be so many challenges for people navigating the system that already exist and are going to be harder, that case management is so important. And I'm not sure how the 525, if that was just the benchmark price. It seems low for a fee to me. And I would just love to see more of a conversation about how we could do more with case management, all of the case management codes, and how to structure case management services and programs, which I think is going to take more conversation than is possible, like in the course of this, getting these fees set. But maybe it's a bigger initiative over the next year or something, that I think the time has come. So.
Becca, I'll speak really briefly to the care coordination issue. To be honest, part of the challenge is that there are not many states that are covering those codes. And so for many of them, there's like maybe one rate out there that's available. And so to have more confidence that it's an appropriate rate, we would really want to do a rate study, and we don't have time to do a rate study. And so the code that we did land on seemed like a substantial care coordination service, and there were enough states where we felt comfortable that the rate was going to end up at an appropriate place. I will also just share that, generally speaking, we don't think that the best way to reimburse for care coordination is through fee for service. But we're in our system we are right now, and we're also not going to, implement a dental medical home or anything within the next couple of months. And so we recognize that care coordination is really important. And so we wanted to cover what we could where we had more of a basis in the short term for a rate, but agree that there is certainly room for further conversation about how we can improve care coordination of services.
Yeah, and don't get me wrong, $5 is better than nothing. And just to even get it in, people start coding it and start using it and thinking about how to do it. I think it's a great first step, and maybe there are ways we can learn from the medical side, as well over time. So thank you very much.
Thanks, Becca. To get more people in, I will jump over to Dr. Reinke, and you should be able to unmute now.
Hi, thank you very much for taking my follow-up here. Just to kind of echo what Dr. Round said earlier as well, and to flesh that out a little bit. Again, I just think that there needs to be more of an investigation into the orthodontic codes. To be qualified to be an orthodontic patient under the main care system, you have to meet a certain degree of difficulty, meaning that the case is more complicated, or there's more difficult ways, or it's a more difficult case to treat than many of the other cases. So for instance, the cases that are tackled, that are approved by main care, are more difficult than probably 70% of the patients that I see in my private practice. So when we're considering the insurance reimbursement rates, these are the hardest cases that should be, in my opinion, reimbursed at a higher rate. And furthermore to that, I hear what you're saying about comparing it to commercial insurance companies and basing it on a percentage of that. But I would be willing to bet that the majority, if not all, orthodontists in Maine that are in private practice simply do not participate with those carriers because they feel like their rates, their full rate, is insufficient to cover an orthodontic case. And I think also to kind of echo what Dr. Round was saying and what I was saying initially, there are other states that are when you add up the total reimbursement for orthodontics for Medicaid in those states, I would be willing to bet that Maine is by far at the bottom for the total reimbursement package. And the unfortunate thing is, I hear you saying that there's a priority for the surgical cases, and I think that certainly should be. But I think that if we look at the landscape of orthodontists that participate in Maine care in Maine, it is dwindling, and it will only dwindle further. There's a number of great organizations out there that are kind of trying to hang on with the orthodontics, Catholic Charities being one of them, Community Health being another one of them. And they're simply no longer going to be able to do that in the current rate environment, even with the proposed increases. And I think as it is, at Catholic Charities, where both Dr. Round and I help out, I think there's something like a 6-month waiting list to be seen, if not more.
Thank you for those comments, and acknowledging the difficulty in collecting the data to identify benchmarks. As Michelle mentioned, for a different service, our alternative would be to conduct a full rate study to be able to collect more data thoroughly from providers themselves on the exact scope of service and level of effort required to provide that service. And that, again, is something that we just didn't have the time to do for this round. I can't commit to doing something similar to for a future round, But if the data is not reliable, that would be the alternative. So we've done the best we can do with the data that's available at hand. And we'll definitely take your comments and look at the data in more details, just for more due diligence.
Thank you, and thank you for doing that. I mean, I think it's my feeling that our reimbursement rate in main care orthodontics is probably, even with the proposed increase, probably at least 30% to 50% less than it is in most other states.
Thank you. For our next question, Dr. Kaylee Williams.
Hi, I have just a couple things I wanted to ask about. I wanted to comment again on the oral surgery rate and the potential 2-year reassessment. I just want to make the comment that there are generations of people who have not received preventive care at this point. For preventive care really to have the impact on dentition in the long run, it needs to be happening from a really young age. We know that kids who develop a lot of cavities tend to, in their primary teeth, are much more likely to develop cavities and have that go untreated as adults. So I would just be really hesitant to say that 2 years is enough time to get through that. It's really not uncommon, unfortunately, to be taking multiple teeth out of 20-year-olds, 30-year-olds, 40-year-olds, all the way up. It's not something that I think the preventive services will be able to really have an effect on in the short term. So my concern, and I know we're saying that it will be reevaluated in 2 years, but I just draw a lot of concern that that is just not going to be enough time. So I guess just reiterating that. Additionally, I noticed in the diagnostic codes as well that the reevaluation post-operative office visit code is being slated to be removed. And I'm wondering if that's because of how similar it is to the code above it, the reevaluation limited problem focused. And I was just reviewing in the CDT codes, and they are different. The limited problem focused is kind of more about trying to determine a continued issue, where a post-operative office visit can be really important, especially if we're doing a lot of oral surgery and extractions. There's a lot of comorbidities with diabetes and other health care issues that will delay or result in non-ideal healing. Then we often need to see people back within a week or so to evaluate if further treatment needs to be done to improve that healing. So I think that people probably could use that other code, but there is a difference between the two. And I just wanted to make that comment as well. And then my last question is, I did notice that the resin restorative rates, while they're increasing, there's many that aren't increasing by much. And when I think about what the commercial insurers are paying up to a 3 and 4 surface restoration, it's $300, $400, and these rates still aren't necessary. Restorative is right in between. It's not preventive. It's not that ultimate extraction, but there's a lot of life that can be given to a lot of teeth with those codes as well. So I didn't know if there was any discussion about those increasing at all either. And I think that's all I have at the moment.
Thank you. So yeah, for your rate questions, those rates would have been set based off of the standard methodology that relies on the benchmarks. So understanding that not all rates will be able to increase to where all providers would want them. We have still tried to prioritize the services that we can in a consistent way as we're able to. Regarding the removal of the reevaluation code, I think that would be a discussion with the policy unit. I, again, don't think that they'll be prepared to speak to that today, but we can take that back and address that in that next forum.
Yes, I have noted that comment, so thank you for the comment.
Great, thank you. So next question from Julie Allaire. You should be able to unmute now.
Hi, yes, Julie Allaire. I'm with Catholic Charities, which manages the Jesse Albert Dental Center. I didn't realize I still had my hand up. I think both Dr. Round and Dr. Ranke really captured our concerns about the orthodontic rates. And I think what I would add to it is the type of reduction in the rate that's been calculated would really jeopardize the financial model. And we know that we are one of the major providers of orthodontic care in Maine, and we're very concerned about the impact that could have on our ability to continue services to this population, which really has no other alternative. So we'll put some specifics in a letter to you that really recap what both Doctors Ranke and Round have said, and hope to work with you offline more.
Great, thank you for that feedback.
Thank you.
I do not see any other hands raised. Are there any other questions that I have missed in the chat? All right, oh, I do see one new hand. Google Pixel 6, you should be able to unmute yourself. If you could just say your name as you unmute, that would be great.
Hi, good afternoon. Can you guys hear me?
Yes.
Thank you. My name is Genko Stanilov. I'm Chief Dental Officer with Community Dental. We do represent 6 offices throughout the state, and for the past couple of years, we've been working a lot with patients with special needs and people that are in recovery programs. And we've utilized sedation services for quite a few of them because they are unable to tolerate procedure under local anesthesia for one reason or another. My understanding is that the 9239 code and 9243 code right now is going to need a pre-authorization. Am I correct?
Sorry, the question was whether they require a pre-authorization.
Correct, for D9239 and D9243 codes. And the D9248 for oral sedation.
I would defer to the policy unit. I don't know if anybody has that answer off the top of their head.
My question is, we're trying to provide care for those patients, and we're trying to expand sedation services to, we're right now in Franklin County. We're trying to go in all of our offices to provide sedation services. And my concern is, because that was my understanding from the sheet that was provided, that if they would need pre-authorization, that will put a burden on those patients and might delay their supportive care. And I just wanted to make sure this is addressed, because for the past couple of years, I'll have patients traveling all the way from Presque Isle to utilize our sedation services. And those patients need to make a 4-hour trip every time they'll be seen for a consult, and then pre-authorization going back and forth, that might delay their care. And I just want to, from our perspective, we are providing very unique services for patients that need those those procedures. And I'm trying to make sure that we will continue doing this without delaying their care.
Great, yeah, thank you for those comments. I will make sure to record that for the policy unit to be able to address that in more detail at the next forum.
Great, thank you.
All right. Let me do another quick scan of my chat questions. Don't believe that I have any other questions, but if I've missed any, please raise your hands. And if my co-hosts have received any questions, feel free to chime in and raise those as well. I do see one more question from Mike Dowling. You should be able to unmute yourself.
Great, thank you. I want to echo what Dr. Stanislaw said as well, the importance of sedation services for main care patients. I'm a pediatric dentist, so we utilize those services a lot. In looking at the fee schedule that was released, we're seeing general anesthesia fees decrease and deep sedation fees decrease. The levels that they're decreased to are below what any anesthesia providers provide those services for, which, in our case, for example, we end up having to pay an anesthesia provider in excess of what we're reimbursed. So we're providing those services at a loss already. And the rates, although they may be based off of methodology, do not reflect what the cost of providing those services in the state is without any actual incentive to provide them for our patients, besides our own ethical obligations too.
Yeah, thank you for those comments. I'll note that the methodology does increase the rate for nitrous oxide. I know that's not necessarily an appropriate replacement for deep sedation, but just wanted to note that there will be some codes that do go up based on the existing methodology. And we'll definitely take your comments back for further review. All right. So it looks like the questions are slowing down. Thank you all for your participation today. Your feedback is really appreciated. We, as Michelle mentioned at the beginning, we are really excited to engage with this process for the first time and have this public forum for discussion of the rates prior to finalizing them. We're still new to the process. This is my first time having a public rate forum. So thank you for your patience and for all of your questions and comments that you've passed along today. Michelle, did you want to say any other closing comments?
I was just going to ask David, because some people were still joining pretty late in the presentation. So could you repeat how you would like participants to submit any comments?
Oh, yes. So let me actually put that up on the screen. So if you have written feedback, additional comments or questions that you would like to pass along, please email those to Jessica in our rate setting unit. She'll be compiling all of those questions and making sure that we can capture all of those appropriately. Her email is listed here on the screen right now. It's also listed in the materials that were posted online and in the e-message that announced this forum. So it should be available in multiple places, and she will be the one to follow up with.
Thanks, David. And I'll just add my thanks once again for your participation this evening, especially as I know that many of you were doing your day jobs during the day, for which we really appreciate. And so again, we'll be sending out notice in the near future regarding the May 18th forum that will look more in depth, much more in depth on the benefit side of things. And thanks for your partnership, and have a good evening.